I will outline the general statistics of extracranial targets treated and primary, then more deeply touch to primary prostate cancer, and later to briefly review some salvage treatment cases for prostate cancer, and at the end outline the future perspectives. So, unfortunately, we currently do not have a reimbursement for our radiosurgery treatments yet, so there are not hundreds of extracranial targets treated, but 45 patients, altogether 60 lesions. And as you see, lung lesions, there are quite a large proportion, spine lesions, liver lesions, and the largest part are prostate localization. Also some pelvic lymph nodes, pancreas, prostate bed relapses, retroperitoneal tumors, and some occasional cases in other parts of the body. What kind of tracking methods were used during this period? So the main part was used fiducial static tracking for prostate, prostate bed, retroperitoneal tumors, and also pelvic lesions further away from the spine. Then the X-side spine for the lesions which are close to vertebral column. It's also for lesions in spinal canal, pelvis close to sacral bone, and synchrony fiducial for moving targets, which is one of the most benefit of CyberKnife system, this ability to track the moving targets without any breath hold techniques. It's lung, liver, pancreas, metastasis in sternum, and thoracic lymph nodes. A little bit touch to the markers. We mostly placed gold anchor tiny fiducial markers because of reduced risk of complications. Mostly it is used without anesthesia. Only those cases where deeply in parenchymal organs implantation should be done, then it's necessary premedication. And usually it is ultrasound guided. Most complicated cases are done by the invasive radiologists, and they prefer ultrasound guidance. But for some cases where it is not possible clearly visualize the needle, then the CT is additionally used. And in very complicated cases, both methods are used. Ultrasound machine are moved to the CT room, and then both treatment methods are used to properly set markers in the right positions. As I mentioned, the less is the diameter of needle, then the less is probability of complication. And this is here is a diagram for the lung cases. If the 18 gauge needles are used, then this is 24%, and very few if this is 22 or 25 gauges needles are used. And it's the same regarding rectal bleeding. Only the minor difference in technique that these tiny markers, they should be pushed out from the needle in order that they form the ball shape, not the thread shape marker. There are some cases, renal cell cancer, metastasis, solitary metastasis in lung. So patients received radiosurgery with 12 grays, 5 fractions, and 6 months post-treatment patient made a PET-CT with FDG, so no extra lesions in other parts of the body, and also this primary lesion is controlled and do not accumulate FDG. But unfortunately, this patient had soon after this investigation solitary metastasis in brain, but also was treated with a single fraction radiosurgery with 22 grays, and patient continues to enjoy her retirement and enjoy her life. So this is a retroperitoneal tumor example. This is a breast cancer patient with oligometastasis in liver. There was one lesion in liver, treated with 12 grays in 3 fractions. The dose was a little bit lower because of the close proximity of the heart, and also 2 solitary lymph nodes were treated, and So I recently contacted patients, so the disease is under control. There is no signs of other metastasis. This is the case of solitary pancreatic cancer. There we also, whenever patient is ready to undergo PET-CT, we do our best to exclude the regional metastasis. It is very frequent for pancreatic cancer to have these regional metastases. What was the toxicity of these first cases? So there are some part of tiny lesions where patients really doesn't understand when doctor asks, do you have some side effects? What are you talking about? Yeah? But some patients has minor complaints, but no additional medications needed, and also significant part needs some additional medications. And for us, 2 patients only was necessary to hospitalize. One pancreatic cancer due to the swelling, prominent swelling in pancreas and jaundice, and another patient with irritation of parasympathetic nerves and vomiting after the radiosurgery of retroperitoneal tumor. The results, well, actually the tumors and localizations treated is very different, so there is not like a scientific data. It's very heterogeneous patient group, but anyway, so local control of the lesions are in most of the cases we have followed up. There were cases of death from new metastasis, from many new metastases for 2 patients. There are some patients which has local control of treated lesions, but new metastases appeared, and other chemotherapy or other treatment methods are received. And 2 cases with marginal progression currently under suspicion, one hepatocellular carcinoma and another one with treatment of bone metastasis in scapula. There is a suspicion of activity of surrounding muscles of scapula. So, and conclusions so far, we have used CyberKnife for radiosurgery, that it's safe, sufficiently effective for body targets. It has a reliable continuous target tracking ability and automatic adjustment of the beam that is very comfortable. But of course, good appropriate marker positions are mandatory for 3D localizations of the targets, especially for moving targets, it's important. And treatment toxicity, of course, is of concern if there are serious concomitant diseases, as we have in hepatocellular carcinoma, where hepatitis C was present and where previous treatment have been received, and also in large volumes, if tumors are large. And the next part regarding primary prostate cancer, we have 20 localized prostate cancer so far, and 1 locally advanced prostate cancer. This locally advanced prostate cancer, actually it was quite an elderly man, where quite high PSA was diagnosed, but PET-CT did not show any additional metastasis other than a lymph node package near the pelvic wall. The initial pelvic wall was PSA was huge, but PSA is very sensitive and very specific, and there is a quite low probability that there are some other lesions. And patient received hormonal treatment before and later radiosurgery. And what are the proportion of the prostate cancer according to risk groups? Majority is intermediate risk cancer. Low risk cancer patients we treat if patient insists on willingness to receive the treatment, and also according European urological guidelines, if there are some criteria which is do not allow to watchful waiting or deferred treatment, active monitoring of these patients. Patient quality of life were controlled according to expanded prostate cancer index composite. PSA pre-treatment and during follow-up was measured. And doses were used. We stratify for low-risk cancer. We still deliver lower doses. For intermediate or high-risk patients, we strive to increase the dose. Yes, it was very interesting previous presentations to listen other point of views. I suppose that this might cause different response in these cases, but simply in order to prove it's necessary very large number of cases to review in order to get evidence-based, statistically significant results. We use PET-CT for intermediate and high-risk patients also to exclude pelvic and distant metastases, as they have increased risk, and PET-CT with gallium PSMA is very specific and sensitive, so we used also to double check these metastases, because CT, MRI or bone scan doesn't give sufficient evidence of no metastasis. We have also our own evidence then these previous treatments did not show any metastasis, but PET-CT reveals new metastasis. So these are our other parts from the protocol. And this is one case of intermediate risk cancer of young man. So there is a dominant lesion in prostate detected in the PET-CT. We also use MRI to detect this lesion. Simply if it is concordance, if we see in MRI the changes, early accumulation in contrast medium in T1 sequence, and we see in PET-CT accumulation of isotope, then yes, this is dominant lesion, then we strive to increase the dose as far as it is possible according to dose constraints. And this is the PSA dynamics. Well, it reduces with a different rate, but actually only first patients reduced the lowest, the nadir. And there is, for example, just an imagination. This is from Alan Katz comparison. We are just in the first part of this follow-up. Toxicity, the main toxicity we have met in the next 2-3 weeks after the radiosurgery, but later it reduces. Unfortunately, during these first weeks, we did not manage to that patients feel the questionnaires. Maybe during these first 2-3 weeks, they will mark higher toxicity, but later, after 2 months, for example, the toxicity for most of the patients returned to baseline. Gastrointestinal toxicity, there were, in the beginning of treatment, there was more cases with rectal irritation, but then we changed the suppositories, what we prescribe for prevention of toxicity from rectal side. Bowel toxicity is a minor cause because we treat with a pre-filled bladder, so the bowels are moved away from this treatment region, and the main toxicity from the gastrointestinal tract is from rectum. And now when we introduced different suppositories, there are no major complaints about this. Sexual score, or only few patients fill this questionnaire. Well, this is also quite stable, but of course very few results and short follow-up yet. So, and some side effects to be mentioned. One case of severe pain during bowel movements, but disappeared after a few weeks. One case of continuous rectal bleeding, but patient continuously had to receive the blood thinners due to the heart disease, coronary heart disease. And 2 cases of repeated irritation of urethra. For one case, it was found that it was chronic infection, and so we prescribed treatment, so we hope that it will disappear. And conclusions, of course, as I said, follow-up is not so long, but until so far, Prostate radiosurgery has acceptable early toxicity, and first results about efficacy is promising. PSA drops, and we continue to follow up. Then I will outline, review some salvage radiotherapy cases, what might be interesting for you. We have different types of relapses treated. This is a patient which was treated with robotic surgery, and unfortunately there was positive margins, and also PET-CT revealed that there is a relapse in bladder wall, and this is a MRI of this case. And it was taken a decision to perform radiosurgery for this patient. And as the target is very deformable and very variable according to bladder feeling, we decided to treat with the urinary catheter, and it worked very well because then the bladder was not filled, it was emptied, and the lesions stayed stable, and treatment was well done. Another similar case is only patient had surgery 7 years ago, and later after this received radiotherapy, and again relapse found in PET-CT. This is MRI image, but PET-CT also revealed lesion in a bladder wall, and so the radiosurgery also was delivered. This is also a case of oligometastatic patient. He received surgery at first, then PSA started to rise. It was prescribed radiotherapy to prostate bed. It slightly decreased, but then again continued to rise. And PET with gallium PSMA found 3 nodes in pelvis. Pre-treatment PSA was 7.18, and radiosurgery to hold these nodes was prescribed. First node according to spine, the second 2 nodes was fiducials were implanted, and only to this lowest node the dose was reduced. Oh no, this is not the slice of this lowest node, but of this lowest node dose was reduced due to the previous treatment. It was just on the margin of the treatment which was delivered for the prostate bed. And this is a case of relapse after radiotherapy. Actually, the real radiotherapy was not prescribed because the patient had prostate cancer, known prostate cancer, but then the rectal cancer was diagnosed and rectal excision was made, and adjuvant chemoradiotherapy was prescribed to regional lymph nodes, including prostate. But of course, these 45 grays, what was delivered for the lymph nodes, it's absolutely insufficient for the primary prostate cancer. And soon after, relapse was diagnosed, and patient received androgen deprivation therapy for several years. But then resistance started to appear, and so in PET-CT there was also node detected between the urethra and bladder neck. So we prescribed radiosurgery with a lower dose to the whole prostate, but increased dose to this dominant node. And the patient, very well, the toxicity wasn't high. And later, also one case of relapse in regional lymph nodes. Patient also received radical prostatectomy, but then PSA started to rise, and these 2 lymph nodes were detected, and 1 metastasis in rib. And we treated these 2 lymph nodes, but unfortunately PSA started to go down, but later again started to rise, and recently he made in the beginning of September repeated PET-CT, and on the opposite side of pelvis there is another lesion, and 1 lesion in the rib. So just above our place in the third rib, we have treated the fourth rib. So patient started androgen deprivation therapy, but there is a question, of course, whether it's possible to treat these additional lesions. So until so far, this salvage radiosurgery is quite well tolerated, except one case where urinary tract infection was lately reported. Local control is provided in all cases, but follow in all cases except this case where additional metastasis appeared. And at the end, I will outline some future perspectives. So here are PTV of ordinary radiotherapy. It's 1 centimeter around the prostate and 0.7 to the rectal wall. So it's huge, right? Everybody will agree. This is the 5 millimeters and 3 millimeters to rectal wall. Actually, it's also not small, yeah, if compared to the head treatments. And how we can reduce this PTV in order to increase the precision, reduce the toxicity, and maybe even decrease the number of fractions. So at first, we bladder volume control is of great importance, because according to bladder, the prostate is deformed. Then we found in these retreatment cases that catheterization gives a good results, very stable bladder feeling, and this might be done. It's complicated to do 5 times for the patient, but if the number of fractions are reduced according to this, then it might be easier for patient and for personnel. Precise registration, this is of course. Then online tracking, there is already Calypso mentioned. There is another system what we reviewed recently. It's Rapilot. There is another system. If Calypso has implanted markers, it has one implanted marker with a wire connected, with the ability also make a dosimetry in vivo to check real dose in prostate. And some centers also reduce without such an online tracking the PTV, but this is very tricky. If you look to the patterns of prostate motion, it's very unpredictable, very irregular. For that case of patient, that might be acceptable, but for others it's very tricky. We cannot treat the target, and therefore online tracking might give additional precision in order to reduce this PTV to, I don't know, 1 or 2 millimeters. Okay, what else can we do according to scientific data? It depends on the aggressiveness of protocol. The potency sparing is from 15, reduction of potency is 15 to 20%. And I believe that we may even further reduce this toxicity and spare the men's potency if the anatomy is favorable. There are cases, of course, when penile bulb are very close to prostate. These are not favorable, or, for example, nerve bundles are surrounding prostate. This is a very unfavorable case for potency sparing. And but for other patients, it also, if specially attention paid to these aspects, the potency might be spared, and a lot of men choose radiotherapy and radiosurgery due to these aspects, to avoid surgery, which is more harmful. And as Dr. Jurashevich already touched these previously published trials, this is a trial by Mayer et colleagues, multi-center trial presented in Astro, quite homogeneous dose distribution with very low toxicity, and we can have also heterogeneous dose distribution with very increased dose to some part of the prostate, and with urethra sparing, which is reported by the Fuller and his team from San Diego this year. And yes, very good results with PSA continuous decrease, and for low risk control is 100%, very good results, but the toxicity is higher, as you see, comparing to previous data by Mayer. So we have really already data with to adjust and to choose different strategy. So, and I believe that we are heading to the personalized radiosurgery of prostate cancer. We can slightly increase somewhere between these two strategies, increase heterogeneity. We can implement online monitoring or online tracking for prostate cancer in order really to reduce this PTV and take into account all critical structures, ureter, bladder wall, rectal wall, and other structures, and also take into account patients' preferences in quality of life. There are some patients which really do not pay attention, where sexual function is not an importance, and some men who are ready to die if there's a risk of harm his sexual function. So, and there is also genetics. There is data in last year that single nucleotide polyformism is one of the factors which might predict high toxicity for prostate cancer radiotherapy, increased toxicity. For those patients, of course, maybe other dosages should be used or not prescribed radiotherapy. But for others who do not have these certain gene sequences, might be used even higher doses safely. And so our goal is reach the optimum between clinical efficacy and risk of side effects. And it might be that also we will reach one day when the body radiotherapy will be delivered as the head radiotherapy, radiosurgery in single fraction. And actually it happened already 3 years ago by the Munich colleagues, where low risk cancer received as in brachytherapy, it's also single fraction, 19 grays in single fraction. Okay, thank you very much. And we are also doing to enlighten, to clarify something in the science. We are planning to build a trial clarifying the role of radiosurgery in high-risk prostate cancer. If we about low and intermediate risk, everything is quite more or less clear. Then regarding high risk, there is very large questions for whom, for which patient groups, etc. So we are planning to do such a trial. Thank you very much for your